Now, when we look at the pre-renal and ischemic pathophysiology, because of the defective increase in effective circulatory volume, the central baroreceptors get activated and they release angiotensin II, norepinephrine, AVP or ADH hormone. What this norepinephrine do? It is a potent vasoconstrictor, causes vasoconstriction of non-essential vascular beds to maintain renal blood flow and to maintain GFR. But if there is still hypotension, if there is still decrease in effective circulatory volume, these defensive mechanisms fail, which leads to ischemic injury to the renal parenchyma. So, preferential constriction of the efferent arterioles, there is even synthesis of the prostaglandins, autoregulation, everything try to cope up to maintain the BP. Which further, so this, if ischemic injury to the renal parenchyma happens, because if this hypotension is still present, this fails this renal autoregulatory defense. So what will happen? There will be endothelial dysfunction, medullary congestion, medullary congestion, and tubular epithelial cell damage. And this will lead to, everything will lead to reduction in this GFR. Then recovery of this renal perfusion, regeneration of this tubular epithelium occurs, which can lead to recovery of this GFR. But again, if this persists, there will be more and more damage, more and more congestion, and even this will not get reversed. So when we look at this pathophysiology of ischemic cause of the acute renal failure, decrease O2, what it will do? Increase vasoconstriction. In response to what? Leukotrienes, angiotensin II, thromboxane A2, decrease in vasodilatation, increase endothelial smooth muscle damage, and increase leukocyte endothelial adhesion, vascular obstruction. And there is also loss of polarity, apoptosis, necrosis, tubular obstruction, everything leading to inflammatory and vasoactive mediator release, further triggering this cascade and further leading to renal failure.